Welcome back. Today we're going to discuss Chapter 18, which covers cardiac emergencies. As I said in the last chapter, which covered respiratory, between respiratory and cardiac, that represents a huge amount of the medical emergencies that we see in EMS, and it's also a big proportion of the things that you as EMTs can do to treat patients and to prevent them from deteriorating. So being able to recognize cardiac emergencies and all the different types of cardiac emergencies that can happen and being able to detect that and then treat it early is key to patient survival. So between cardiac and respiratory, this is the meat and potatoes of a lot of the medical emergencies that we go on. So we are going to cover some review at the start. So we're going to be doing the anatomy and physiology of the heart. Again, this should be review at this point. Then we're going to talk about the different types of cardiac conditions that we can see and different type of cardiac emergencies we see. Then we're going to end with cardiac arrest, so a review of CPR and some broader things that we as EMTs need to keep in mind when we're running a cardiac arrest. And then we'll finish up with the times that we withhold resuscitation for patients and the certain criteria that we have to meet in order to do that. So at this point in class, it is critical that you know everything about the anatomy and physiology of the heart. If I told you a drop of blood was at any point in the body, you at this point should be able to tell me every single thing that's going to pass through to return to that point in the body again. So, for example, if I told you that we had a drop of blood in a vein in the leg, you would know that the blood would go from the vein in the leg to the inferior vena cava. That would dump into the right atrium, go through the tricuspid valve into the right ventricle, through the pulmonary valve into the pulmonary artery, to the lungs, be oxygenated, come back through the pulmonary vein, enter the left atrium, go through the bicuspid valve, go into the left ventricle, through the aortic valve, into the aorta, into the arteries, into the arterioles, into the capillaries, into the venules, and then back into the vein. That's something that you should be able to do from memory at this point. If you can't, please, please, please study this, because the rest of this chapter and really the rest of this class banks on you being able to know the anatomy and physiology of the cardiovascular system. In addition, we should be able to know the cardiac conductive system at this point, so knowing the SA node, the AV node, the bundle of His, the right and left bundle branches, and the Purkinje fibers. So again, at this point, we are relying on your ability to know that from memory. So if you don't know that from memory, please pause and review all that stuff. You should also be familiar with the composition of the blood. Composition of blood is about 55% of it is plasma. Around 40 to 44% of it are red blood cells, and about 1 to 2% of it are platelets and white blood cells. So know the general composition of the blood, that most of it is plasma and very, very little of it is white blood cells and platelets. So this is all stuff that we should have down at this point. And we are relying for the rest of this chapter and rest of the course that you guys know this by heart. Again, you should know the correlation and relationship between the heart and the lungs, and also between the heart and the rest of the body. So that stuff is critical at this point. Also, you should know how the heart and your blood vessels kind of interact in order to raise or lower the blood pressure. So you should know that the heart, if you have a drop in blood pressure, can increase its rate and it can increase its contractility in order to raise blood pressure. So it can change how hard it beats and how fast it beats, and both of those should raise your blood pressure because we're moving blood faster and we're moving it harder. We also should know that the blood vessels themselves can dilate or constrict in order to raise or lower blood pressure. And also, you should have shock down at this point. So shock in its true sense is hypoperfusion. Doesn't matter how it happened, because we do have the different types of shock, but shock in itself is hypoperfusion, no matter what the type of shock it is. So here's a quick diagram of the four chambers of the heart and the blood flow through there, as well as all the different valves that interact in there. So if you need, you can pause this slide and take a quick look at it just for review. So going back more into the heart has several properties that can be manipulated, whether that is something that the body is doing itself or something that happens to the body. These are three things that can change in the heart. First one is contractility. So contractility is how hard the heart can pump. So it can either pump harder or softer. And in conjunction with contractility, we also talk about the ability to refill itself between beats. And remember, that's called preload. That is the amount of blood that gets into the chamber before the heart actually fires. If there's no blood in the chamber, it doesn't matter how hard you fire, you're still not going to put out any blood. So preload is critical to work well with contractility because you need the blood there to actually pump out. You can pump as hard as you want, but if you only have half the amount of blood in there to start with, you're still not going to put out a good amount of blood. Next part of the heart that we need to be aware of is the excitability of the heart. So that is the ability of the heart to depolarize and create a electrical pulse through it. So if you have a part of the heart that is not conducting electricity or it's not excitable, then we cannot send a pulse wave through it and it will not actually contract. So if the electrical part of the heart is not working well, then the heart itself is not going to pump. So if we change anything in the excitability of the heart, we'll either make it pump easier if we increase the excitability, or we're going to make it pump very ineffectively if it decreases the excitability. And then the last one is something we've talked about several times, is the rate. We can change how fast we pump the heart, because if we need more blood to move through the system, the heart can go faster and move more blood. Flip side, if we don't have enough rate, if it's very low, then we can't move enough blood to be effective, and so we fall into hypoperfusion. So I know that we've labeled all the heart valves several times at this point, but we haven't really talked much about why the valves are there. So the heart valves are there to prevent backflow of blood back into a chamber. So there's a valve between the right atrium and the right ventricle. That's the tricuspid valve. That valve exists so that once blood gets into the right ventricle, it's not going to pump back up into the right atrium. Sometimes heart valves start to malfunction and they allow blood to backflow through the heart, and that's a very serious condition that needs to be fixed. So you might have someone say that they've had a heart valve repair or a heart valve replacement. So know what the heart valves do. Also talking about the heart valves allow for the one-way flow of blood, and when your heart is not pumping, so it's at rest, the valves allow for passive flow of blood. So you have the blood in your atria, and that needs to get to the ventricle to be pumped out into the body. So during rest, 75% of the blood that's in your atrium actually falls down into your ventricles, just passive flow of blood. So when the atrium contracts, the first part of your heart, because remember your heart goes bum, 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 bum. The first bum is your atria contracting, and the second part is your ventricles. When the atria contract, you're actually only pushing about 25% of the blood that started in your atria out, because the other 75% has already fallen down into your ventricles. That's why people who have conditions where your atria stop contracting, we're going to talk about that a little bit later in this chapter, but a condition could be atrial fibrillation, where your atria don't actually contract anymore. The patient doesn't die because your body has that passive blood flow to get blood into the ventricles without atrial contraction. So you can live without atrial contraction. It's just preferred that we do have that, because then we have 100% of our preload into our ventricles. So talking about the blood vessels now. We do have to remember that the arteries are under much higher pressure because they're much closer to the actual pump. If you remember in class, I talked about if you have a big fan and you're standing in front of the fan, you're going to have a lot more air movement towards you rather than if you're standing 50 feet away from the fan. So that's the same thing as the heart. If you're closer to the heart, you're going to be under a lot more pressure than being further away from the heart, like the veins. So in order to withstand that amount of pressure, your arteries have a lot more muscle to them. Then they actually have 3 different layers of muscle. They're labeled the tunica externa, tunica media, and tunica intima. Now, if you can do a little bit of investigative research into this, the 3 layers, the externa is your external or outer layer, media is the layer in the middle or medium, and the intima is your inner layer or the intimate layer. So those are the 3 different layers and where they sit in your arteries. The arteries will start to narrow and go down eventually to the arterioles and then the capillaries. And capillaries, again, is where the gas exchange actually takes place. So that's where we offload the oxygen, we onload the carbon dioxide and any other waste products and other things that a cell needs, like glucose. Capillaries, because you have to have that exchange happen, are very thin. They can get down to 1 cell in width, which means that our blood has to fit through there. That will become an issue when we have large particles trying to get through there, which we'll talk about in the next chapter, which is diabetic emergencies. So know that we get very, very small, and then when we come back up, we get very large. And remember, in your veins are under much lower pressure because, number one, we're away from the pump, and also when you get so small that you're only 1 capillary wide, it's going to reduce a lot of your pressure. You just can't force that much pressure through that small of an opening, so it's going to take that pressure down quite a bit. And so our veins have one-way valves in them as well to prevent backflow coming back to our heart, because they're under such low pressure that sometimes they can't move the blood themselves, which is why we rely on muscle contraction, which is why we talked about in respiratory emergencies deep vein thrombosis, or DVT, which occurs when you don't have that muscular contraction in your deep veins to help push that blood up. So keep all that stuff in mind with blood vessels in relation to your cardiovascular system. And again, our blood is mostly plasma, 55% plasma. Red blood cells make up between 40 to 45%. And then your white blood cells and platelets make up about 1 to maybe 2%. Now, yes, if you do the math right here, that equals more than 100% if you go to the max of all of these. So know that these numbers are a little fluid. You could have 54% plasma or 56% plasma. You could have 39% red blood cells, or you could have 46% red blood cells. So these are fluid numbers, and this is the general range that they stay in. So know the basics of your blood is mostly plasma. The majority of it is plasma. And then the next most abundant source by far is red blood cells, and then your white blood cells and platelets account for very little percentage of your blood. So again, shock, and no matter what the form of shock it is hypoperfusion. So if you have low perfusion, you are in a state of shock. Doesn't matter the cause, you are in shock. The causes matter a little bit because it will dictate how we can reverse the cause, which will help shock reverse itself. But just know, if you're treating shock, you are treating low perfusion, which means you have an issue with one or more of the following parts of the body. You either have an issue with the heart, or the pump. You have an issue with the blood or the fluid, and or you have an issue with the blood vessels or the hoses, the container. So either you have an issue with your pump, your fluid, or your container. You can also have an issue with the lungs if you are not able to oxygenate the blood because oxygen is not getting to your lungs. That will cause an issue. So do keep in mind that the lungs does affect shock because low perfusion if you have low oxygen. So lungs will be a common source of shock, but the main treatable things that we're looking at are an issue with the pump, the fluid, or the container. All right, so now that we've covered all the review parts, and again, if you don't have this stuff down pat, then rewind, go to other lectures, go to your textbook, and make sure that you have that stuff memorized at this point. So now that we've done that, we're going to go into the different types of cardiac emergencies that we're going to see. We're going to start with acute coronary syndromes. So kind of like COPD with respiratory, acute coronary syndrome is a umbrella term for several different types of emergencies that we see. So sometimes acute coronary syndrome, it's abbreviated ACS, so I'll say ACS from now on. It is sometimes just called cardiac compromise because that's pretty much what's happening with the heart. The heart is compromised somehow. And it's compromised because it's not getting enough oxygen. So there's a few different ways that the heart might not get enough oxygen, but that is the baseline issue that's happening, is the heart is hypoxic, so low oxygen in the heart. So the two things that really fall under acute coronary syndrome, the first one is acute myocardial infarction. So we abbreviate that AMI. Layman's terms, that is a heart attack. So acute myocardial infarction. If we break down that word, acute means sudden, so not chronic. So a sudden, then myocardial is the tissue in the heart, so that's the heart muscle itself. Then infarction means death. So it is acute, so happening now, death of the heart tissue. The heart tissue dies because of the lack of oxygen. If we don't have oxygen perfusing the heart, the tissue will start to die relatively quickly. There's two different forms of AMI. You have something called a STEMI, and STEMI stands for ST segment. That's something that you see on an EKG. So ST segment elevation myocardial infarction. So that's where we're looking for elevation of the ST segment. That's not something at the EMT basic level you guys are going to be looking for, but you are going to be doing 12-lead ECGs and transmitting them to the hospital for interpretation, or an ALS provider might show up and interpret a 12-lead. So that is one form of AMI or heart attack, and that's one that we can see on a 12-lead. You also have NSTEMI, which stands for non-ST segment elevation myocardial infarction. An NSTEMI is a heart attack that we cannot pick up on a 12-lead ECG. The only way that we can actually see an NSTEMI happening is by doing blood work or doing more invasive imaging of the heart. So that's why anyone with chest pain, even if their 12-lead is clean, so it's not showing that the patient's having a STEMI, we still have to transport these people to the hospital for further evaluation, because about 20% of all acute myocardial infarctions are NSTEMIs. So they're ones that we cannot see on a 12-lead. So that does become huge in our patient care, because patients will say, oh, how does my heart look on the 12-lead? And we might not be able to see anything on the 12-lead. Again, you guys as EMT basics can't interpret these, but you'll transmit them to the hospital for interpretation. So that might look fine, but we can't rule out the patient having a myocardial infarction or not. So that is one type of acute coronary syndrome, is your acute myocardial infarction. And then the next one is called angina pectoris, or angina for short. We're going to get more into both of these. So the symptoms of acute coronary syndrome, whether it's a acute myocardial infarction or angina, they're relatively similar. So we can talk about the symptoms as a whole, applying to both types of issues that we're having. So the number one symptom that we look at is chest pain. So there are a lot of other things that can cause chest pain or cause other symptoms that we're about to talk about in acute coronary syndrome. So do realize that you are going to have other conditions that might mimic the symptoms of acute coronary syndrome. So that's what makes our job very hard to do, and that's why we can't just give someone a clean bill of health, because we can't fully rule out whether it's a cardiac condition or something else causing these complaints. We can usually rule cardiac in, so we can say we're pretty sure that this is a cardiac event, but it's very hard to rule cardiac out if they're presenting with any of these symptoms that might be something else, such as pleuritic chest pain. If you remember that from respiratory, pleuritic chest pain is pain caused by the pleural space in between your lungs and your thorax. And that can be the source of a lot of pain that will present as chest pain. So all chest pain is not necessarily cardiac related, but we have to treat it as if it's cardiac related because we can't rule it out. So that's what the second bullet point in this slide says, is anyone that has any symptoms of acute coronary syndrome, and we'll cover the symptoms in a minute, we have to treat them as though they're having an acute coronary syndrome. We can't just say, oh, well, I think that it's pleuritic pain, because we cannot say with 100% confidence that it is. And remember, in our differential diagnosis and talking about our assessments, we have to assume the worst possible case scenario first. So it's a pretty well-known fact that chest pain is a complaint of acute coronary syndrome. If someone's having chest pain, they always think that's their heart. So that's very true, that chest pain is something that we have to consider to be acute coronary syndrome. Now, chest pain is not always what you would think when you think heart attack chest pain. Chest pain is very subjective for people, so you can have many different feelings of the pain. A big one that people complain of is a crushing feeling, or feeling like there's someone sitting on your chest. So they'll say it's crushing, it's heavy, it feels like a pressure. There's other ways that people can feel pain. So it could be squeezing, it could be sharp, it could be shooting, it could be stabbing. So chest pain can take a bunch of different ways of feeling. And that's why we need to remember that this is a subjective part of our assessment. We cannot go into someone's body and say, oh yes, this is a stabbing pain. That is something that they have to tell us, and they rely on their experience as a person to tell us about this pain. So just because it's not what you would immediately think is, oh, this is a heart attack, because they're saying, oh, just it feels like I'm a little uncomfortable in my chest, or it feels like there's like someone sitting on the middle of my chest. That is most likely cardiac related pain. You know, a lot of people think that cardiac related chest pain is some overwhelming sensation that is just killing you with pain. A lot of people are just complaining about some discomfort, or feels like their chest is heavy. So keep that in mind, that any sort of discomfort in the chest area could be cardiac related pain. Cardiac related pain also tends to radiate places. It doesn't have to, but that is a telltale sign, is if it radiates. Some common areas that it radiates is your shoulder, your left arm, and sometimes your jaw. We also have areas that we call referred pain. So if you have pain just in your jaw, or just in your shoulder, or just in your left arm, that could be cardiac related pain. And that's pain that's being referred from the heart to that place. And we're going to cover that in the next slide. So this is a chart of your typical referred pain areas. So as you can see with the key on the right side, there's a lot of different areas that pain might be referred from depending on what organ is being affected. And this has something to do with how your nerves are organized in your brain, and how neural pathways are formed. And that's why you can have chest pain, or you can have pain coming from the heart that you actually feel in your jaw instead of your heart. Or, for example, you might have pain from your liver and gallbladder, which is in your abdomen, and you might have the pain referred to your right shoulder. So this is kind of some tricks that your body has, just based off of how your nerves and your neural pathways are formed in your brain. So you might want to pause and take a quick look at this diagram. There's a lot of different organs that can refer pain to a lot of different areas, but as this one points out, this dark kind of magenta purpley area is heart, and you can see it goes all the way up to the neck and jaw right here, and then it radiates all the way down into your pinky. So any pain in this area and this area, as well as the back over here, so middle of the back, so any pain in these areas could be cardiac, even if they're not complaining of just chest pain. So if you're complaining of pain just in your jaw, you have to think that this could possibly be cardiac related pain. So acute coronary syndrome, males are typically easy. Males present classically. So males, you're going to be seeing, most of them will have chest pain in the left side of their chest. It's going to be the typical picture that you think of when you think someone having a heart attack. They're going to have that type of pain. Females are typically much harder to diagnose, especially elderly females. Elderly females and elderly people in general are a little bit harder to assess pain on because their nerves are diminished, so they have less sense of pain usually. But females will be complaining of other secondary symptoms, which we are going to talk about in the next slide. So yes, females could have chest pain, but they might not, and they might have some other symptoms, and we have to be very suspicious of cardiac related pain. So some other symptoms that we see, you can see these in males, it's just with females you might only see these symptoms, so be very, very suspicious with females. So dyspnea, which is difficulty breathing, anxiety or the feeling of impending doom. That is a big one. If your patient says, I feel like I'm going to die, that's their only complaint is, I feel like I'm going to die, you should believe them. We always teach this, and I kind of took it with a grain of salt originally until one year is actually on Halloween. I did a call for a 55-year-old male who was very anxious and just said, I'm going to die, I'm going to die, I'm going to die. I brought him to the hospital. I put him on the cardiac monitor just to make sure that everything was okay, because the heart rate was a little high, it was about 120. And while we were waiting in line to get him a room at the hospital, he went into cardiac arrest. So, otherwise healthy male, he just said that he felt like he was going to die. That was his only complaint. He had no pain, no other complaints. He just felt like he was going to die, and he was feeling anxious about it. And he did go into cardiac arrest. We did get him back because he went into cardiac arrest with us, but that just goes to show, real life scenario, these people who have that feeling of impending doom are likely having a cardiac event. Other symptoms, nausea or pain in the upper abdomen. We call that epigastric because it's above your stomach. So if you have pain in the epigastric area, especially in females, you can't rule out cardiac. So you have to be thinking this might be a cardiac event. Sudden onset of sweating, which we know sweating or pale skin, because it's usually a sudden onset of pale skin and sweating or diaphoresis. Those are signs that we have some sort of hypoperfusion. That hypoperfusion, if it's sudden with no other explanation, we have to think it's because our pump is failing. Other things are abnormal pulse, especially bradycardia. So if your pulse you measure is 30 or 40 beats per minute, then you have to think something is failing with the pump, which is your heart. And then abnormal blood pressures. You have to think if there's, again, no other explanation for the blood pressure being really low or really high, that something is happening with your pump. So you have to think this could be an acute coronary syndrome. You can also have just some back pain, especially back pain that's your upper back between your shoulder blades or behind your left shoulder blade or scapula. Another big one is lightheadedness and dizziness. There's been more than one patients I've had with full-blown cardiac events happening that their only complaint is lightheadedness and dizziness. Same goes with weakness and fatigue. If you are suddenly weak and you feel like you're really tired with no other explanation, you have to think that's your body shutting down because it's not getting enough blood flow because your heart can't pump as effectively. So, there's a lot of patients that will call for this type of stuff that are not having acute coronary syndromes. There's a lot of like 70-year-old people who are weak all the time and they just feel a little bit more weak today. That's typically not an acute coronary syndrome. But you have to be very, very suspicious when you have any of these complaints. Any of these complaints should warrant an evaluation from an ALS provider, just to rule out that they do not have an acute coronary syndrome happening. So when we're talking about acute coronary syndrome and assessing it and trying to rule in or out, a huge thing that can help you with assessment is your history gathering. And this is more than our typical history gathering. Usually our history gathering involves pertinent past medical history. This goes well beyond that. So for example, like a asthmatic patient, you ask, do you have any history of breathing problems? And that will help you get most of the history that you need. With cardiac related complaints, you need to go much deeper, and that's going to provide a lot of insight as to whether or not you should be much more suspicious of a cardiac event or not. One of the biggest things is family history. People who have history of parents or grandparents or even siblings that have massive cardiac problems, such as a history of a heart attack in the past, because that's what they're going to say. They aren't going to say, oh, they've had a myocardial infarction. They're going to say, oh yeah, my dad died from a heart attack at age 40. So people who have a history of anything like that happening in their immediate family, you need to be much more suspicious of acute coronary syndrome. Family history is critical to know. You also need to know their personal history. So if they've had a history of heart attacks, so if they say, oh, I've had 4 heart attacks in the past, you should be very suspicious that they're going to have another one. Also think of their risk factors. So these are the past medical problems that will increase the risk factor to have a coronary event happening, such as high blood pressure, high cholesterol, diabetes. Those are a few of the ones that can cause cardiac problems. High blood pressure will cause cardiac problems because your heart's just working too hard for too long of a period of time. So that will increase your chance for having a cardiac event because your heart is being stressed for a very long period of time. High cholesterol, the blockages that happen in your body are caused by usually excess fats or excess cholesterol in your bloodstream. That cholesterol will start to stick to itself and it's going to form clots. If a clot forms in your heart, that's what causes a heart attack. And then diabetes, we'll talk about that a little bit more in the next chapter where we actually discuss diabetes. But long-term diabetes will be a big risk factor for acute coronary syndrome. Again, we'll dive into that for chapter 19. More history that you need to gather is their personal habits. Most people know that a history of smoking increases your chance for acute coronary syndrome significantly. So ask, are you currently a smoker, or were you a smoker and quit? A lot of the elderly people have quit at some point during their life, but just because they quit doesn't mean that their risk isn't very high for acute coronary syndrome. If they smoked for 20 years prior to quitting, they're going to be at a higher risk even if they quit 20 years ago. And also ask about recreational drug use. Recreational drugs can wreak havoc all over your body, so be at more higher suspicion for people that have a history of drug use. Also, and this is one that is overlooked a lot, people who are on birth control, especially ones who are on birth control for a very long period of time. Birth control can increase your risk for heart disease or heart attacks up to 80%. And this is because the hormones that are contained in birth control increase your chance for clotting much more. So it raises your clotting factors a lot more. So people who are on long-term birth control use, I'm talking 5, 10, 15, 20 years of birth control use, will have a much higher risk for developing some sort of acute coronary syndrome. So going into our actual management, so what we do for acute coronary syndromes. Again, this is usually regardless of if it's a myocardial infarction or if it's angina, mainly because we can't fully rule out what it is in the field. So we want to do our primary assessment, support your ABCs if there's any issue with that, get your history. Again, it's critical that we get a good history on acute coronary syndrome patients. Then do your full physical exam, so that's your secondary. Remember, use your OPQ STI. Get your vital signs, and then if you have the capabilities to do a 12 lead, so if you are on an ambulance that has a cardiac monitor, do a 12 lead and then transmit it to the hospital. So we'll talk about that in a little bit later from now. But this is something that you have to do in person and actually get the training on hands-on of how to do a 12 lead. And a 12 lead is designed to get a view of the heart from 12 different angles so that we can see what's going on with the heart. So if a person's having a STEMI or not. Going on into actual treatment, you want to have a patient in the position of comfort. Usually that's a semi-Fowler's or Fowler's position, which is sitting up. Give oxygen if needed. So remember your criteria for oxygen administration. You should be looking for respiratory distress and assessing a good SpO2 level. Always want to transport these patients. Anyone who is experiencing any complaints of acute coronary syndrome, so remember that long list of symptoms that we have, any of those people should be evaluated at the hospital. And then we are going to be giving our medications as appropriate. So one medication that we give is nitroglycerin. Remember, this is at the EMT basic level only if the patient is already prescribed nitroglycerin. If you want to have a more in-depth conversation about nitroglycerin, go back to our general pharmacology presentation. Remember, our dose is 0.4 milligrams. It's given sublingually, which means under the tongue, and you let it dissolve under there. And we're giving this for people with chest pain, have a prescription, and have a systolic blood pressure over 120. So that's one form of what nitro looks like. You should be able to see the type of nitro that you guys carry on your own vehicles. So again, our systolic blood pressure has to be above 120. Ask about history of erectile dysfunction medication within the past 72 hours. And again, this is something that we ask for both males and females because erectile dysfunction medication can be prescribed for blood pressure to females. And erectile dysfunction medication is a vasodilator. Remember, nitroglycerin is a vasodilator. So the reason why we need to be careful is we don't want to be giving two medications of the same drug class. This used to be a hard and fast contraindication. It's now just a precaution. So if they have used erectile dysfunction medication in the past 72 hours, think twice about the blood pressure. If their blood pressure is 122 systolic, probably withhold the nitro. But if it's 180 systolic, you're probably safe to give a dose of nitroglycerin and see what happens. After you give a dose of nitroglycerin, you can repeat it every 5 minutes until the patient's complaints are relieved. So if the patient has no more chest pain, you don't have to give nitro anymore. Make sure that their blood pressure stays above 120. This means that you have to reassess your blood pressure every 5 minutes before you give another dose of nitroglycerin. So reassess your patient continually when you're giving nitroglycerin. The second drug that we can give for acute coronary syndrome is aspirin. Aspirin, as a reminder, our dose is 324 milligrams administered orally. We give what's called baby aspirin because it is chewable. So we give 4 81 milligram tablets of baby aspirin that the patient chews. The act of chewing it up and swallowing it makes it get into our bloodstream a whole lot faster than a pill that has to be digested first. So that's why we're giving baby aspirin. Our indications for administering aspirin are chest pain. You also have to make sure that the patient is not allergic to aspirin and that we are not suspicious of gastric bleeding. That's because aspirin is an anticoagulant, so it's going to allow the blood to not stick as easily, and we don't want to have an anticoagulant if we're actively bleeding internally. Other contraindications for aspirin is they have to be able to safely swallow the aspirin. So if a patient is altered or at baseline cannot swallow things safely, then don't administer aspirin because you don't want them to choke and cause an airway problem. So like I said, 12 leads is something that we really should be doing in person. So if you missed this lecture at all, please come to see me in person and we'll go over 12 leads hands-on. So as far as 12 lead placement goes, we have 4 what are called limb leads, and they're labeled as such. They make it pretty easy. So you have RA, which stands for right arm, LA, which stands for left arm, RL, which stands for right leg, and then LL, which stands for left leg. So those are our 4 limb or trunk leads. When you put those 4 leads on, you will end up getting a tracing. That's our basic tracings. Again, you don't have to worry about tracings too much. We just have to worry about actually obtaining a 12 lead. So these 4 trunk leads, they have to be placed where they're labeled. But we try to put them as far away from each other as possible. Another rule is you cannot put it directly over a bone. If you see, all these are right below our clavicle. So you want what I call the meaty area, because bone does not transmit electricity very well. These are picking up the electrical impulses of the heart. So we want electricity to be able to transmit to it very easily. So your right arm and left arm leads in this diagram are actually pretty darn close to where you should be putting them. Technically, the best place to put them is all the way down on the arm near the wrist. But us in EMS, most of our interventions we do to the arms. We're doing our blood pressures at the arms. If you have an ALS provider with you, they're doing their IV at the arm. So we're manipulating the arms quite a bit. So that's why I like to put them up here near the clavicle, because we are not moving this area nearly as much as we're moving the arms down here. Your right leg and left leg, the technical best place to put them is down at the feet. I usually go down to the calves because the calves have a lot more meat to them. So it's a lot better to not have bones taken away from that electrical signal. So try to put them on your left calf and right calf. If you can't access that area, because some patients it's almost impossible to remove their clothing to expose their calves, you can put them on the abdomen. So try to put them nice and low on the abdomen, right near the pelvis. Again, not on the bone. The reason why the abdomen is not the best place is because a lot of people have a lot of fat in that area. Fat jiggles, and jiggling fat, especially when someone's moving, is going to give us a bad tracing. So that's where our trunk leads go, or our limb leads go. Then you have your called precordial leads. So these are labeled V1, V2, V3, V4, V5, and V6. These kind of surround where the heart sits, because heart sits about like that in the chest. So these are getting actual good looks at the heart. If you imagine these being cameras pointed at the heart, these are pointed in the general directions of the heart that they're looking at. So there's a guide over here, so you can see V1, and all these are color coded, so no matter what manufacturer for the EKG machine you're using, these are all the same color. So V1 will always be red. Same with your trunk leads. These are always the same colors. So like your left arm lead will always be black. Your right arm lead will always be white. Left leg will always be red. Your right leg will always be green. So the V1 through V6 labeled here, and then if you look, it'll tell you exactly where this is supposed to go. So V1 is your fourth intercostal space at the right sternal border. So right there, if you see intercostal space, that's our space between our ribs. So we have first intercostal space, second, third, and then fourth, and then we're going to the right sternal border. So V1 goes right there. V2, fourth intercostal space at the left sternal border. So exact same spot, because intercostal space are same spots. So 1, 2, 3, 4, just the left side of the sternal border. V4 you actually place after V2. So if you look at V4, we go mid-clavicular line in the fifth intercostal space. So we go fifth intercostal space, which is right here. Mid-clavicular, our clavicle is here, so we go right down the middle, and we have V4 placed right here. The reason why we do V4 first is if you look at V3, V3 is midway between locations of V2 and V4. So in order to get the midpoint between V2 and V4, you have to place V4 first. So if you see, this is directly in the middle between these two. We then skip to V5. V5 is your anterior axillary line on the same horizontal level as V4, which is your fifth intercostal space. So your axillary line, your anterior axillary line, is where your arm meets your torso. So where this is pressed against the torso, that is where V5 goes. That's your axillary line. Again, same horizontal level as V4. Okay. Then V6 is your mid-axillary line. So we started with our anterior axillary line. This is now our mid-axillary line on the same horizontal level as V4 and V5. So mid-axillary is the middle of your arm, or middle of your armpit, coming straight down, same horizontal line as V4 and V5. So you can see a picture of where this looks like, and you have the full explanation. So go ahead and pause this if you need to study this anymore. It is important that we know the definitions of where to put all this stuff, but again, we need to actually do this hands-on in person. So feel free to see me, and we'll do this over and over again in person if you would like. So going into causes of cardiac conditions. So this is where we're going to actually talk about the specific cardiac conditions and why it's happening in the body. So we're going to revisit the conditions of acute coronary syndrome, acute myocardial infarction, and angina. We're also going to be visiting some other cardiac conditions that you're going to see. So keep in mind that heart problems are caused by several different disorders that can affect the condition and function of both the blood vessels and the heart. So starting with coronary artery disease, or CAD is how it's abbreviated. So coronary artery disease is a long process, but at the core of it is it will start to narrow or block the interior of your arteries. Now this is done with two different ways. First one is where we have buildup of fatty deposits on the inner walls of your arteries. So when you have high cholesterol, which is high fats, we also refer to it as hyperlipidemia because it's high lipids. Lipids are fat. So when you have high cholesterol, you have so much fat going through your vasculature that it's eventually going to start to stick to the arteries themselves. And once one sticks, another one will stick to that, another one will stick to that. It starts to build up over time. Now, in arterial sclerosis, that's a condition that usually causes coronary artery disease. You might find that an artery, the inside might be a little more rough than normal. There might be some cracks in the muscle, and that will cause a lot more fatty deposits to stick to that crack because it's no longer smooth on the inside of the artery. So that is the disease process that causes coronary artery disease, is arterial sclerosis. And what boils down to is those fatty deposits are going to narrow the inner vessel diameter, which makes it so that not as much blood goes through. Now this can build up over time to the point where there is zero blood flow through there. You can have 100% blockage of your artery. Now when this is happening in your coronary arteries, these are the arteries of your heart, that's where you have hypoxia happening because either it's restricted the blood flow so you can't get enough blood through, or it's completely blocked the blood flow altogether. So a clot can also be called a thrombus. So a thrombus is a complete occlusion of blood flow caused by formation of a clot on the rough inner surface of a diseased artery. It's what we just talked about with arterial sclerosis. A thrombus can break loose from where it's lodged. If a thrombus breaks loose and it's free flowing in the body, it's called an embolism. So that embolus can lodge somewhere else and it will occlude another part of the body. We just talked about this in respiratory with deep vein thrombosis, or DVT. That's where the clot forms in a vein somewhere in your body, and then it breaks free, and then it will flow and then lodge in your pulmonary vasculature and becomes a pulmonary embolism. So these terms shouldn't be brand new for you. We discussed it all in respiratory, and if you forgot what DVTs and pulmonary embolisms are, please go back and review that because that is key stuff that we need to keep in mind. So coronary artery disease, like I said, it happens over a long period of time usually. Usually this is a fatty buildup over years and years and years and years of time. So overall, it will reduce the blood supply to your heart, and that's what causes the majority of our cardiac-related medical emergencies. That is what causes our heart attacks. So when your heart is deprived of oxygen because it can't get enough blood, it signals you, and typically that signal is pain. It doesn't matter what part of the body is experiencing low oxygen or hypoperfusion, it's usually going to trigger you with pain. So that's why we see chest pain as one of the most common symptoms of a heart attack, because we have reduced oxygen level and our body's signal for reduced oxygen is pain. Now the pain can either be the result of ischemia or infarction. So ischemia is dying tissue. So this is tissue that is hypoxic. It is not functioning properly because it doesn't have enough oxygen. It is currently dying but still alive. Infarction is complete death. So if you're having infarction of tissue, that means that those cells are dead. They're not coming back. So you have to start with ischemia. Ischemia is always the first step because that is being hypoxic and dying, and then infarction is actually death. And if you remember, we call heart attacks acute myocardial infarctions. So that means that you're actually having death of heart tissue. So moving on into aneurysms. I'm sure that you guys have heard aneurysm at some point in your life. There's several different areas that you can get an aneurysm. So aneurysms are usually caused by long-term hypertension, so long-term high blood pressure. And that's because arteries have muscle in them, and that muscle is designed to take the pressure from your heart at 120 millimeters of mercury pressure. That's what they are meant to do. They can take temporary spikes in blood pressure because your body is meant to compensate for certain events. So they're designed to handle higher blood pressure. But if you have higher blood pressure for a very long period of time, they're not designed to take that much pressure for that much time. So if you have, say, a systolic blood pressure of 180 and a diastolic of 120, and you have that for months or years, the muscles in your arteries are going to wear down over that period of time. Number one, from the higher amount of pressure from each stroke of the heart, so the 180, but also if your diastolic is really high, if it's 120, your arteries are only supposed to take 120 as a pulsating pressure, not as the constant resting pressure. So not only do you have a really high pulsating pressure, but you also have high residual pressure at all times in the system. So the muscles are going to wear down over time because they're just being too strained for too long. So when they wear down, they're going to start to kind of buckle. If you have weaker muscle and you still have the same amount of pressure, it's going to start to balloon out and it's going to get thinner because the muscle can't actually contain that pressure anymore. So an aneurysm is the ballooning part of it, and in the next slide there's going to be a little diagram showing that. So the aneurysm is where the muscle wears down and it starts to balloon. It's very thin and weak in that ballooned area. A bursting of that balloon is called a rupture. So a ruptured aneurysm will cause very rapid, very life-threatening internal bleeding. Depending on where the rupture is, typically anyone who has a rupture is going to die very quickly. If you have a rupture, say in your aorta, so you have an aortic aneurysm and it ruptures, unless if you are actively in surgery with everything cracked open and ready to repair that right then and there, you're probably going to die. There's no fixing that amount of blood coming out that quickly. Same with a brain aneurysm. If that goes, typically you are going to die. So aneurysms are very, very, very dangerous to have, and that's why detecting them before they rupture is key. So as you can see in this diagram, the top is the ballooning. So that is where we actually have the aneurysm happening. So right here, this is the aneurysm. And then when that ballooning bursts, because the walls are just so thin and so weak, that's where we have the rupture of the aneurysm. So talking specifically about aortic aneurysms. So that is an aneurysm in your aorta. As you know, the aorta is the main blood vessel that comes out of your heart. That's the only blood vessel that comes straight out of your heart. So if you have a rupture in the blood vessel that takes all the blood out of the heart, that's a problem. That's why people that have aortic aneurysms that rupture, unless if you are actively in surgery to repair it, you're probably going to die. So one very common area for aortic aneurysm to develop is in your descending aorta. So your aorta turns after it comes out of the heart and then heads down. There's branches that come off the aorta from that turn. So you have like your carotid arteries come off your aorta right there at the turn. Your brachial arteries come off your aorta at the turn. But it makes a big curve and then it heads down to get to your abdomen and legs. So a common area for that aneurysm to develop is in your abdomen, and we call that an abdominal aortic aneurysm, or otherwise referred to as a AAA. So patients might tell you that they have a AAA. That means that there's the aneurysm in their abdominal area. You can also get them in other areas, like I talked about with the brain aneurysm. So other arteries can get aneurysms. It's just typical to see in your aorta, sorry. So some signs that we look for to detect abdominal aortic aneurysms, and especially ones that may rupture or have ruptured, is if you palpate the area in the abdomen, there might be a mass that is pulsating. So if you are feeling around and you feel this big mass in your abdomen and you feel a pulse in it, that's probably the ballooning aorta, so the aneurysm, and you can feel the actual pulse of your heart going through that because you have such thin muscle there. So that's usually a sign of a impending rupture. When it does rupture, patients typically complain of tearing pain. And that's a very specific feeling. They feel the tear in their vasculature. So if you have a patient complain of tearing pain in their abdomen, be very suspicious that it might be a ruptured aneurysm. And again, this is someone who is going to probably die very quickly. And when it does rupture, you will see immediate signs of shock. This will be hypovolemic shock because you're losing your blood internally. So, like I said, aneurysms are not something to mess around with. And if that does go, unfortunately, these are patients that are almost always going to die on us. So as you know, the heart is governed by its electrical system. If you have a disruption in your electrical system, you will not be able to pump because the electricity is what stimulates the muscle to actually contract and pump. So any malfunction of your electrical system will result in what we call dysrhythmia. Remember, dys means difficulty, and rhythmia is rhythm, so difficulty with the rhythm. Your dysrhythmias will include bradycardias, so slow heart, tachycardias, fast heart, and also rhythms that might not produce a pulse. Those rhythms we'll get into a little bit later, but those will make the patient go into cardiac arrest because your heart is not actually pumping blood anymore. So that's cardiac arrest. So this should be review at this point, but your heart has a preferred electrical system, but we also have backup systems in place in case if our heart starts to fail. So remember, our heart is governed typically by our SA node, our sinoatrial node. That is located right above your right atrium, and it has an inherent firing rate of 60 to 100 times a minute. This should be very familiar because the normal heart rate in an adult is 60 to 100 beats per minute. So that means that the sinoatrial node is firing at its inherent firing rate. Sinus atrial node encompasses the atria with its impulse, so it sends the electrical pathway through all the atria, then it gathers at your AV node. That's your atrioventricular node that's located right in the middle of your heart between your atria and your ventricles. That will gather the signal, pause for a quick second, like a millisecond or two, and then send it down to your ventricles. Your AV node has an inherent firing rate as well. That inherent firing rate is 40 to 60 times a minute. So if your SA node stops working, your AV node can serve as a backup and send its own electrical impulse down to your ventricles. Once your AV node sends its impulse, it goes through your bundle of His, goes into your right and left bundle branches, and then circles around your ventricles in your Purkinje fibers. Now, your Purkinje fibers, it's the last stop of your electrical system, they also can take over the firing of your heart. If it's not getting any signal whatsoever from the AV node, it will start to fire itself. Now, the inherent firing rate of your Purkinje fibers is 20 to 40 times a minute. So we know that a slow heart rate is not necessarily effective. So if you have a heart rate that is 20 because it's coming from the Purkinje fibers, yes, your heart's firing, but is it going to be perfusing well? Typically not. And that's why we don't want our Purkinje fibers to be taking up our heart rate. We don't want our AV node to be taking over our heart rate. We want our heart to originate from our SA node, and that way it's at the correct rate and it follows all the correct pathways. So if you do have a patient that has an electrical problem, measuring their pulse can help indicate that if they're having an electrical problem. So if you take their pulse and it's 24, you need to start thinking, okay, either our SA node is not working effectively, so it's firing well below where it should be firing, or this is within the inherent firing rate of our Purkinje fibers, which means that our heart is in serious trouble electrically to where the only signal we can get is coming from the Purkinje fibers, which is our last hope. So this will sometimes help determine if you are having an electrical problem. That being said, you can have a heart rate of 30 that's coming from the SA node. So just because it's below the inherent firing rates of these nodes doesn't mean that the impulse is not coming from that node. That's only something that we can see on an EKG. But this is a nice tool to help you assess to tell you if the heart is in electrical distress or not. One specific electrical malfunction that we need to discuss is atrial fibrillation, sometimes abbreviated as AFib. So in atrial fibrillation, our SA node has stopped sending a strong signal to the heart. And as we know, each cell in the heart is capable of generating its own electrical impulse. That's called automaticity. So each cell can generate an impulse. So when the cells in the atria are no longer sensing that the SA node is sending them signals, each cell is going to try to generate its own signal on its own. So this is a problem because then you have 100 different signals coming from 100 different cells in your atria. So this causes your atria to try to contract 100 different times in the same time period that it's supposed to contract once. So you end up having the atria kind of quiver. If you think about like a bowl of jello and you shake that jello, that's what your atria are doing because it's getting so many signals from all over the place that you can't effectively contract the heart with one strong impulse. So you have one little area contracting from one impulse, one little area contracting from another one. There's no rhyme or reason to it. So that's one part of the issue. The next part is your AV node. Remember, that's the first stop of the electrical impulse. It's meant to only get one impulse from your SA node. So it takes that impulse and that sends it down. Well, in AFib, it's getting hundreds of small little impulses all coming at the same time. So it's trying to decipher what is the good impulse and what's not. So it has a very hard time doing that. So it's going to randomly send impulses down to your ventricles. It's just going to randomly take ones that it thinks are legitimate impulses and send them down. This results in an incredibly irregular heart rate. So the term that we use for AFib is we call it irregularly irregular. So that means that there's no rhyme or reason to it being irregular. It's not like it speeds up, then slows down, then speeds up, then slows down type of regular. It is all over the place, no rhyme or reason to what's happening. It's just complete random. So that's the two areas of concern with AFib is we have the top of our heart is just quivering, so it's not actually contracting at all. And then we have a very irregular ventricular response. So the danger with AFib is, if you remember, when we're talking about heart valves, uh, about 75% of our blood will passively go from our atria to our ventricles. So our atria don't need to contract in order to move blood to our ventricles. But we still have that 25% of blood that's just stuck in the atria. It's not being contracted out. So if that blood, that 25%, pools in like the corner of an atria and there's no electrical impulse to make the muscle contract, that blood is just going to sit there for a while. And if blood sits in a certain place for a while, what do we have? We have coagulation of the blood. And coagulation of the blood causes a blood clot. So if the blood clots in a corner of the atria and then it eventually moves away and goes down into your ventricles, you then have a blood clot that is in your ventricles, and your ventricles will shoot it out. So if it's in the right side of your heart, your ventricle will shoot it to your lungs, and you're going to end up with a blood clot headed towards your lungs. You'll end up with a pulmonary embolism. If it's in your left side of the heart, the left ventricle is going to contract and shoot it out to the body. And the number one place that you might have it end up is in your brain. So it might shoot up straight to your brain. If you get a blood clot in your brain, that's called a stroke. Another place that you might have it go is it might circulate back into your coronary arteries. If you get a blood clot in your coronary arteries, that's called a heart attack or a acute myocardial infarction. So these are all very bad things to have happen. And so anyone who has atrial fibrillation is usually placed on a blood thinner. So a blood thinner makes it so that your blood does not want to coagulate nearly as well. So that way, when it's sitting in your atria, if it doesn't want to coagulate, it's not going to form a blood clot nearly as easily. The issue with patients that have a history of AFib is you should assume that they're on a blood thinner, and if they have any sort of trauma happen, it's going to be very hard to stop their bleeding. People who normally will stop bleeding very quickly will not when they're on blood thinner. They can bleed for hours. So this presents two issues for us. First issue is when we have actual external bleeding, it's going to take a lot of pressure, a lot of time to stop that bleeding stop the bleeding from going. But also, when we have very minor traumas, say a person fell and hit their head, very common call we go on. Someone who hit their head, a normal person might bleed in their brain for a minute or so, and then the brain will clot that area, and you'll be fine. Someone who's on a blood thinner might have a very small bleed, and it won't stop because it can't coagulate. And so these patients will have a very small bleed happening in their brain for hours, days, weeks. And you won't notice these symptoms for when you're assessing the patient because they won't become apparent for hours or days. And eventually, these patients, once they've bled for hours and days, will bleed so much that they put so much blood inside of their skull, which is a sealed area, that you are going to put pressure on your brain. We're going to talk about this a lot more in trauma. But if you have the pressure on your brain, that is going to cause a lot of issues. Again, we'll talk about this in trauma. So anyone who is on a blood thinner and has fallen and hit their head, we need to get them to the hospital for a CAT scan, a CT of their head, because we need to see physically, is there a bleed anywhere? And these are patients that are going to be complaint free. They're going to say they're fine. You know, oh, I just fell, I bumped my head. I don't have any pain, I don't have anything else. But we really need to try to convince these people to go to the hospital and be able to explain the risks of not going to the hospital to these patients. So that's why knowing atrial fibrillation is huge. And also keep that in mind for anyone who is on any sort of blood thinner for any other reason. Because just because you're on blood thinner does not mean that you have AFib. But because you have AFib means you're almost always on a blood thinner. So another thing we need to be aware of are things called pacemakers. So patients who have electrical malfunctions with their heart will typically have a pacemaker implanted into them. This is very common to see in patients that have atrial fibrillation. And pacemakers do exactly what the term says. It makes the pace of your heart for you. So it will take over what your SA node is supposed to do. That's why it's very common to see in patients that have atrial fibrillation. They will implant this into your heart and it will stimulate your heart just like your SA node should do. That way your heart gets its proper beat back. So your atria start contracting and then your ventricles start contracting. A lot of these pacemakers you can actually feel on a patient. It'll be usually on the left side of the chest up near the clavicle. It'll be kind of a box shape. So that's someone that if you are doing a physical exam on, you feel a kind of box underneath their skin, you can say, oh, do you have a pacemaker? And typically they'll say yes. Most pacemakers nowadays also are defibrillators as well. And we have to be aware of this because in addition to the pacemaker doing its normal thing of creating a electrical impulse to make the heart beat regularly, if it senses that the heart goes into a lethal rhythm, it will fire. It will actually shock the heart. And this usually happens when the patient's in a lethal rhythm, but sometimes it might just randomly go off by itself. And patients will feel this. It is a very unpleasant feeling. I once had a patient that his internal defibrillator went off, I think 15 times in my 5-minute transport to the hospital. And he was in a significant amount of pain. It was very traumatizing for him. And I did have him on my cardiac monitor, and his heart kept on going into a lethal rhythm that had to be shocked. So it was doing its job. It was saving his life. But it's something that they can feel, and it is unpleasant. It is very painful. So be aware that these might go off, and people oftentimes will call us when these go off, and typically it means that their heart went into a lethal rhythm. So this is something that needs immediate intervention, because if your heart was just in a lethal rhythm, it probably will go back into it until we treat the reason why it went into that rhythm in the first place. So keep pacemakers in mind, that if you palpate one, ask the patient about it. And also the fact that it might be a defibrillator as well, and it can go off, and we are called for these issues. So going into mechanical malfunctions of the heart. So mechanical malfunctions means that the heart's not pumping the way that it should anymore. So the 3 mechanical malfunctions that we look at, 2 of them are acute coronary syndromes. So we would return to these. So first one we'll talk about is angina pectoris, or just angina. Next one is an acute myocardial infarction, or AMI. Then the last one, which is not an acute coronary syndrome, it's called congestive heart failure, or CHF. So knowing that angina is an acute coronary syndrome, we know acute coronary syndromes are caused by reduced blood flow in the heart. So that's exactly what angina is. It's chest pain that is caused by insufficient blood flow to the heart. Usually, our arteries are narrowed because of coronary artery disease, and our arteries can be a little occluded or blocked because of the coronary artery disease and the buildup of fats in the heart. So that's usually the cause of angina, is we have narrower arteries and we have partially blocked arteries. Usually these patients are going to develop chest pain, and that's the classic sign is chest pain. And the chest pain is usually developed when you have some sort of exertion or stress, because exertion or stress makes the heart work harder, which means it's going to have increased oxygen demand because we need to make more energy. And we can't get that oxygen to the heart because we have the narrowing and blockage of our arteries. And the pain that is classic for angina is a very heavy pressure in the middle of the chest. We call this substernal pressure. So it's below our sternum, but it's a very heavy pressure. People say it feels like someone's sitting on their chest. That is a telltale sign of angina. And remember, angina, being an acute coronary syndrome, means that the heart is lacking oxygen. So it's a very serious condition to have. We also have a specific type of angina called Prinzmetal angina. Now, Prinzmetal angina is angina that's caused by a coronary artery spasming. So if a coronary artery spasms, it's going to constrict very heavily. If it constricts heavily because it's spasming, it's going to reduce the blood flow in the artery. If we can't get as much blood through there, the heart from there on out is going to have reduced blood, which is going to mean it's going to have reduced oxygen amounts. So we're going to have reduced myocardial oxygen, which is an acute coronary syndrome. So it's a form of angina, just the cause is a little different, but our result and our treatment is exactly the same. So our treatment of angina. First and foremost, you support your ABCs. You want to be transporting these patients. Get a 12-lead EKG on them. You want to be giving them oxygen and then aspirin because, again, we can't rule out that this is not a myocardial infarction. So if you have any sort of clot forming, you want to be giving aspirin to make the clot not continue to get bigger. And then if we're able to, remember all the requirements we need, we want to be giving nitroglycerin to these patients. These are the patients that should have nitroglycerin prescribed to them. If you have a history of angina, you should have nitroglycerin prescribed to you. The reason why we're giving nitroglycerin is because it's a vasodilator. So if we take these arteries that have blood flow restricted in them because they're narrow, they have a clot taking up most of the space, or they're spasming, and we give a vasodilator, we make them bigger, it should restore blood flow. So if we make it bigger and it restores the blood flow, we should have the pain go away because we're able to perfuse our heart again. And our goal with angina, especially in the Prinzmetal angina, is if we dilate our blood vessel for the 5 minutes that nitro works for, we are trying to just keep it open until the spasm of the artery stops. So that's why nitroglycerin is a very, very good treatment for angina, and that's why people are prescribed nitroglycerin for angina, because it just gives the body the time to stop that spasm from happening and have blood flow return to normal levels. So moving into acute myocardial infarctions, or AMI, that is, like we've talked about before, where the heart tissue is actually dying because we have our lack of oxygen. Typically, you're going to have coronary artery disease before this happens, but doesn't mean that they're diagnosed with it. It's just that is usually what causes this to happen. A MI or an AMI will always start out as ischemia because if we stop the blood flow, the heart will want oxygen. It's going to be hypoxic, which is ischemia, that's dying, and then it turns into infarction, which is death. So, like I said before, we look for NSTEMIs, which are MIs that we cannot pick up on the monitor, but we can pick up with blood work. And then we look for STEMIs, which are heart attacks that we can pick up on the monitor. Again, you guys are not going to be interpreting these 12 leads, but be aware that we do have several different types of MIs that can happen, which is why transport to hospital is crucial, even if you do not see, or if the interpretation shows that there's nothing bad going on the monitor. We cannot catch everything on our monitors. So it is critical that we get these patients to the hospital so that they can have further tests done to rule in or rule out an acute myocardial infarction. And also, if they're having one, we have to get them to the hospital for treatment. That's where the hospital will actually go in to the heart and grab the clot and pull it out of the body. So this is just kind of a FYI slide. I don't expect you guys to memorize this, but these are some of the major coronary arteries. So these are the major arteries that supply the heart with blood. So some big ones to point out. We have our right coronary artery right here. So this covers the right atria and right ventricle. You have your posterior descending artery right here, which will help supply your right ventricle. You have your left coronary artery and left circumflex artery right here. That supplies your left atrium. And then right down here you have your left anterior descending artery, and this supplies your left ventricle. So if you have something happen right here that affects your left ventricle from pumping, as we know, left ventricle pumps blood to the body, and if that goes, death very shortly follows. So that is one of the worst arteries, in my opinion, to have go. This is just a little diagram of when one of those arteries goes. We start having death in that area, and it's going to get bigger and bigger and bigger. So we have death in the actual tissue area, and when the tissue dies, it's no longer able to function. If we have a big enough area that it can't function, then we won't be able to contract the heart anymore or pass electrical impulses through there. So that has death happen. An acute myocardial infarction that is left untreated will lead to death. So moving on into congestive heart failure. Now, congestive heart failure at its most basic level is the heart is not pumping blood out effectively anymore. So it's an inadequate pumping of the heart. So we talked about this a little bit in respiratory. So what happens is your heart, if for any reason it's not effectively pumping, we're going to have a backup of blood coming into it, because if we can't get the blood out, we can't get as much blood in. So we think about the chambers of the heart, and you just go reverse in those chambers. So for example, if you have congestive heart failure in your left ventricle, and so the left ventricle can't get that blood out to the body anymore, you're going to have a backup into your left atrium, and that's going to back up into your pulmonary vein, which then backs up to your lungs. So if you have a backup of fluid in your lungs, the fluid is going to be under high pressure because we have too much fluid in that space, so it's going to be an incredible amount of pressure, and it doesn't like being under pressure, so it's going to go wherever it can find less pressure. So that fluid will then go into the alveoli, which has much less pressure than the vasculature. So that's where we get pulmonary edema from. If the failure is on the right side of the heart, so if you think of your right ventricle, if your right ventricle is not pumping blood out effectively, so we're not getting to the lungs as effectively, we're going to back up into our right atrium, which is going to back up into our vena cava, and then we're going to follow gravity, and it's going to go down our vena cava, down into our veins, into our venules, into our capillaries, and where's our lowest point, the point that gravity affects the most of capillaries? That would be the feet. So the fluid is going to sit in the capillaries in the feet and legs, especially the lower legs, and it doesn't like being in an area of high blood pressure, so it's going to go out of the capillaries there and just sit in the interstitial space of our bodies. And that's why we will see a lot of edema to that area, because all the fluid is sitting outside of the vasculature in the interstitial space, and that's why we have what we call pedal edema, which is edema of the feet and sometimes the lower legs. So that's a classic sign of congestive heart failure, is someone that has pedal edema that we can see at the feet and lower legs. So congestive heart failure can be caused by several different factors. It might be caused by diseased heart valves or COPD. If you have a myocardial infarction happen, a lot of times congestive heart failure is going to happen afterwards, because if we have death of that tissue surrounding the heart, then the heart can't pump as effectively because the tissue's dead, so it can't pump anymore. So that will oftentimes be a subsequent issue that we see after someone's had a myocardial infarction. Another very common cause of congestive heart failure is a long-term hypertensive patient. The reason for this is because if your heart is pumping harder than it should for a long period of time, you're using the muscles of your heart too much. If you overuse a muscle, it will either get weaker or it will build up muscle to make itself better. So a lot of times when we have long-term hypertension, the muscle of your heart will start to get bigger and bigger and bigger. We call that hypertrophy. So that's high growth. So the issue with hypertrophy is if we get too much muscle in that space, we won't be able to contract as easily and we won't be able to refill as easily because we just have too much muscle in the area to be flexible and be able to contract. If you think of a very muscular bodybuilder, they don't have nearly as good flexibility anymore because the muscle just takes up too much space that they can't move it as effectively. So if we have muscle, too much muscle there that we can't contract effectively, we're going to not be able to put out the blood as effectively, which leads to congestive heart failure. So like I said, this can affect the right side and or the left side. So you can have it affect both sides at the same time, but it can just be right-sided or it can be left-sided. If you remember the flow of blood, if it's left-sided, you're going to see issues in the lungs. So you're going to have the pulmonary edema. If it's right-sided, you're going to have the issues mainly in the body. That's where you have the pedal edema. So they do present differently. Again, this is more of a FYI. Someone who has congestive heart failure will probably know their ejection fraction, or EF. The ejection fraction is the amount of blood that is actually coming out of the heart with each contraction. So you want 100% ejection fraction. That is what we should be having. But these patients can have 50% ejection fraction. That means half of the amount of blood that's supposed to come out actually does. So that's how we measure how bad the congestive heart failure has gotten, is by your ejection fraction. And because of the mechanics of how everything works, this is the main cause of why pulmonary edema happens, because we have the backup of fluid and then it wants to get into the lungs. So some signs and symptoms of congestive heart failure that we look for. It usually causes respiratory distress, so we're looking for a lot of our respiratory distress signs and symptoms because we have pulmonary edema, which causes a lot of respiratory distress. So you're looking for tachycardia because, number one, you might have the respiratory distress, but number two, if your heart can't pump out enough blood with one stroke, it's going to try to do 2 strokes for everyone to get the same amount of blood circulating in the same period of time. That's our body compensating for this. You'll have the dyspnea, which is difficulty breathing because you have the backup of fluid into the lungs. Cyanosis, because we can't breathe as effectively. You might have normal blood pressure, but you could probably be elevated because, like I said, a primary cause of congestive heart failure is long-term hypertension. So these patients might already have hypertension, but also if your body's trying to compensate for the lack of blood coming out of the heart, it's going to try to elevate your blood pressure to make the blood that is coming out more effective. You might see diaphoresis, just like with most difficulty breathings, rales for lung sounds because we have fluid in the lungs, jugular vein distension because we have decreased blood flow in the heart, so it's going to back up, and it's going to back up into our jugular veins, and they're going to bulge out because they have too much blood in them because we can't get the preload under control. And then pedal edema is a huge one, like I said. So moving into cardiac arrest. So like I said at the start, cardiac arrest is something we're going to kind of go through fast because we already did CPR. So we're going to touch some of the highlights and then focus more on managing the cardiac arrest scene and managing a patient as a whole. Yeah, at this point, I trust you guys to know the actual CPR guidelines because you guys are all now certified in CPR. So if you don't feel comfortable with CPR, please see me or review or take another CPR class. Make sure that you are very proficient in actual CPR. So just as a brief reminder, we're following the American Heart Association guidelines. So our chest compressions are at 100 to 120 beats per minute. Our ratio is 30 to 2. The only time that changes is if you have a pediatric patient and you have 2 rescuers, then you go to 15 and 2. The depth of your chest compression is 2 inches or 1/3 the size of the chest. People are different sizes, so follow the 1/3 depth rule a little bit more. because 2 inches might not be appropriate for certain patients. Remember to allow for full chest recoil. That allows for our heart to actually refill with blood. And above all, remember to minimize interruptions in chest compressions. That is a huge one that they're emphasizing lately. Then you want to treat underlying causes for the cardiac arrest to the best of our ability. So if we know that the cardiac arrest was caused by something that we can fix, try to treat that. For example, if the cardiac arrest was caused by hypovolemia because they had an arterial bleed, we want to try to stop that arterial bleed. If the cardiac arrest was caused by very low blood sugar, again, as EMTs, you guys won't be able to fix this, but your ALS partners might try to raise the blood sugar with medication through a vein. So try your best to treat the underlying cause. Another one that we can treat is hypoxia. If it was caused by some sort of hypoxic event, try to bring more oxygen into the body. So remember, we have the chain of survival from the AHA. It consists of 5 elements: the immediate recognition and activation of the emergency services system, early CPR, rapid defibrillation, effective and early advanced life support, and then integrated post-cardiac arrest care. We really want to emphasize teamwork and coordination with all this. As long as we have teamwork and coordination, a lot of things are going to go much smoother, and smoother usually means better patient outcomes. So hopefully we get activated very quickly after cardiac arrest happens. It's usually done by whoever calls 911. So something you have to remember is sometimes you might be the only EMT on scene for a little bit. If you're with a first response fire department, you might be the only person there for the first few minutes. Or it might just be you and your partner there if you're on an ambulance. So keep in mind, good effective CPR requires more than one person. So if you have bystanders or lay people there, especially like a police officer or a firefighter who is not an EMT, use them in the initial stages of CPR. Yeah, I'd rather have a lay person doing my compression so that I can do the airway rather than having to do it all myself. So keep that in mind, that in the first stages, until you can get more help, enlist people that are able to help you. If you have a 80-year-old woman that's the patient's wife, they're probably not going to be able to do effective compressions. So make sure that they are able, willing, and knowledgeable enough to help you. A lot of people nowadays know CPR. Some people don't. So don't try to teach CPR in the moment. But if you have someone who is certified in CPR, especially like a police officer, please enlist their help until you get more people there to help you. So it has been proven over and over again that early CPR greatly increases the chances of survival from cardiac arrest, because if we do CPR, we get the blood moving and we can perfuse the brain. So there's been a big push nowadays to get a lot of lay people trained in CPR. So our goal is to have someone close to the patient immediately that can start CPR. We also try to get CPR trained professionals to the patient. So that's why we have law enforcement dispatched to cardiac arrest, because if law enforcement can get there before you, they can start CPR first. Also, our dispatchers in the 911 system are trained to instruct people over the phone on how to do CPR. Sometimes that's not nearly as effective CPR, but it's better than nothing, and sometimes it is very effective. It depends on the person doing it and how well they can understand the instructions. So effective advanced life support is usually provided by the ambulance. So it's provided by the paramedics who respond to the scene or who meet you on the way to the hospital. Sometimes, depending on where you are and what district you serve, it might be quicker to just get the patient to the hospital than to wait for 20 minutes for a paramedic to arrive. So take your location into account. Whatever the fastest way to get ALS while still maintaining good CPR is going to be your best option. And keep in mind that CPR is usually not very effective in a moving vehicle unless if you have a mechanical device doing it for you. But human CPR, you actually performing the compressions, is not very effective in a moving vehicle. That has been proven over and over and over again. So your integrated post-cardiac arrest care, that is a coordination of several different specialists, team members, everyone. And our goal is to maximize the chance of a neurologically intact survival. So that's not just someone who lays in the hospital for 2 more years on life support. This is someone that can walk out of the hospital and have their brain be intact and still be the same person. So once we get the person back, we want to immediately start the post-cardiac arrest care in order to preserve their brain best as possible. So some keys to that is maintaining adequate oxygenation, avoiding hyperventilating the patient. So that's using our good BVM techniques. You want to be performing a 12-lead ECG and transmitting it to the hospital. You want to find and manage your treatable causes of arrest. So we want to be doing that during the arrest and then after the arrest so the patient doesn't go back into cardiac arrest. You also want to bring the patient to the appropriate destination. So that's usually going to be a cardiac care center, someone that can treat a heart attack or an AMI, because that is oftentimes the cause of our cardiac arrest. So you want a hospital that's able to fully treat the patient. And then sometimes you might consider putting the patient into a hypothermic state. That is not something at the EMT basic level you guys need to worry about. That's not even something that paramedics do in New York State anymore. But be aware that that is part of the AHA recommendations for post-cardiac arrest care for the hospital to consider. It is kind of going out of favor in the recent years, but it is still part of some recommendations. So general managing of your cardiac arrest. When you guys become EMTs, you will probably be the highest level of care on the scene until you're relieved by ALS. So as highest level of care, you are the one who's responsible for the total management of the patient. So that means that you need to make sure everything is being done correctly. You need to delegate your team members effectively. You need to be able to assign them roles. You need to be able to monitor their quality of care. So if you have someone that you assign to compressions and you notice they're not doing good compressions and guidelines with the AHA, either instruct them on how to change or change out the team member. So this is a big task to take, but it's a critical task to take. The person in charge of the cardiac arrest is the one who determines how well this is going to run. I'm not going to tell you it's the one who determines if the patient lives or dies, because you can do everything right and still have the patient die. That happens most of the time. But this will give the patient the best chance for survival if you effectively manage the cardiac arrest correctly. Ideally, the person who's in charge of the cardiac arrest is actually not providing hands-on care. That's because we get what's called tunnel vision, and you're focused on whatever care you're providing, and you forget to look at all the other aspects of the care happening. So unfortunately in EMS, this isn't as much of a realistic possibility, just because we don't have enough providers on scene to where we can afford to have the person in charge stand away from the patient and observe the whole scene and give directions. Usually we need your hands to be able to actually do the tasks. But if you have 5 EMTs on scene, you in charge should be away from the patient, maybe standing at the foot of the patient, and be giving directions from there and not actually providing the hands-on care. That is the best way to manage a cardiac arrest. And if you ever watch one in a hospital, that is what's done in the hospital. The doctor in charge never touches the patient. They are just standing giving directions to their entire team. So again, that's something that's not usually able to be done in EMS just because of the nature of our job and limited resources. But if you have those resources, you absolutely should be hands-off and be giving directions. That way you get to manage the entire scene and the entire patient. So I know you guys know how to use an AED because of the CPR training. So we'll talk about a few more specific things that you should be aware of as an EMT. There are two different types of AEDs. They're classified by how they deliver the energy. So you have monophasic and biphasic. If you break those words down, mono means one, bi means two. So monophasic AEDs send a single shock from one pad to the other. Biphasics send a shock one way, then comes back the other way. So those are two different types of AEDs. Almost every single one nowadays are biphasics. So that is the standard nowadays. Any new one is going to be a biphasic AED. So keep in mind that automated external defibrillators will only shock two rhythms. So they will shock ventricular fibrillation and they will shock ventricular tachycardia. Those are the only two rhythms that they will shock. If the patient is not in those two rhythms, it will say no shock advised. The patient can very much so still be in cardiac arrest. So keep that in mind, that just because it says no shock advised doesn't mean that the patient's not in cardiac arrest. It will only shock ventricular fibrillation and ventricular tachycardia. The most common form of cardiac arrest is a rhythm called asystole or flatline. That's a non-shockable rhythm. So the majority of our arrests that we work are not going to be shockable. So keep that in mind. Now, if they are shockable, absolutely shock the patient because that is their best chance of survival. But keep that in mind, that just because it says no shock advised doesn't mean that they're not in cardiac arrest or that they are not able to be saved. Remember, when you're using an AED, make sure the chest is bare and dry. Be aware of the material the patient is on. You think that that's self-explanatory, but in the heat of the moment, you sometimes forget things. Me personally, one of the first arrests I ran as a paramedic, the person was in a shockable rhythm, and we were carrying the patient up the stairs from the basement. They were in a Stokes basket, which, you remember, a Stokes basket is a metal basket. So we put the patient in that basket. We had 5 firefighters surrounding the patient carrying them, and I tried to shock the patient while they were in a Stokes basket that everyone was carrying. Fortunately, my partner, who was an EMT, pointed that out to me, saying that that wasn't a good idea to be shocking someone who was in a metal basket. But in the heat of the moment, thinking about everything else, you aren't thinking, oh yeah, this person's in a metal basket that conducts electricity that 5 people are holding. Because I knew no one was actually touching the patient at the time, but I didn't think about the surrounding materials. So keep that in mind. Another time would possibly be if you were in sporting bleachers that are metal. Just keep in mind what material the patient is laying in. When appropriate, use pediatric pads. So for your pediatric patients, use pediatric pads. If they're not available, use adult pads. But if the pads touch on the chest, then you have to do the front back position. So anterior posterior position. So one in the center of the chest, one in the center of the back. And the one in the center of the chest should be the one that should typically be the higher one on the right side of the chest. So usually if you're using an AED that you carry on your equipment as an EMT, that's not an issue. But if you are just off duty in public and someone goes in cardiac arrest in front of you and you're using a publicly accessed AED, then that's something that you might run into, is no pediatric pads available. So just keep that in mind. A common test question is, if the pads don't fit on the chest, what do you do? And they always will say, should you cut the pads? You should never cut the pads to fit. So if they are touching and they don't fit on the chest the way they're supposed to, go to the anterior posterior positions. So there's been some debate more in latter years about implants and surgery such as pacemakers. Defibrillation can be performed on a patient with an implanted device. So you should be able to, or you should try to put the pads on the chest in an area that avoids contact with the device. So one of the big ones was pacemakers. Saying, oh, can you defibrillate when someone has a pacemaker? And yes, just don't try to not put the pads directly on the pacemaker, which the pacemaker should be on the upper left chest near the clavicle. That's not where the pads would go anyway. So if they do have other implants, so say they have some sort of vascular port on their right clavicle, just try to not put the pad directly on whatever device it is, and then it should be pretty safe. So here are some of the implants you might see. You might see a ventricular assist device, which it's a pretty obvious thing to see. It's something that ALS will be a little bit more familiar with. Implanted defibrillators, cardiac pacemakers, or signs of cardiac bypass surgery. Again, we can absolutely defibrillate over top of these things, or with these things in. You just don't want to put the pads directly on them if you can avoid it. Like I said at the start of talking about cardiac arrest, we are focusing very heavily on not interrupting compressions. So only interrupt compressions for a very short period and only when absolutely necessary. So only when you're doing something like delivering ventilations for a few seconds. Other than that, we should try to do compressions as much as possible. There are very few circumstances where you should be interrupting the compressions. You should be stopping compressions for rhythm analysis and defibrillation. And the new guidelines actually say in the time that the defibrillator is charging, so between when it says that it's analyzing rhythm and the time that the shock is actually delivered, you should be doing some compressions in that time period too. So they really are focusing heavily on making sure that we are not interrupting compressions. Compressions are key to survival. So when you first arrive on a cardiac arrest scene, if the bystanders are doing CPR, have them stop and verify that the patient's in cardiac arrest. A lot of bystanders aren't very keen to knowing who's actually in cardiac arrest and who is just unconscious and not doing well. So you need to verify that they're in cardiac arrest. So remember, we do our look, listen, and feel, and we are doing that for no longer than 10 seconds. And remember to check a pulse at the carotid artery. So just verify that they are in cardiac arrest, because a lot of bystanders do CPR on patients who are not in cardiac arrest. So we have a few reasons that we can stop CPR once we've started. First one is the patient gets their pulses back. So it's called return of spontaneous circulation. That means their heart is spontaneously circulating the blood. That's abbreviated as ROSC. So if you hear ROSC, that is return of spontaneous circulation. Next one is exhaustion. If you physically are too tired to do CPR and no one is there to relieve you, that's a reason to stop. So if you are physically unable to do it anymore. Next one is if your scene becomes unsafe. That goes hand in hand with the guidelines that we have for every single call. If the scene is unsafe, you are to stop what you're doing and go to safety. Next one is you terminate resuscitation. One reason why you might do that is if someone presents you with a valid do not resuscitate order. So even if you started resuscitation, if you're presented with that do not resuscitate order, or DNR, you are to stop resuscitating. The next one is if it's considered futile. So that's a determination that usually an ALS provider can make, and they have very specific guidelines of what we can do to make sure that this resuscitation is now futile. So that's not usually a determination you make as an EMT, but you might be directed to stop CPR from a higher level of care once they determine that it's futile. Then the last reason to stop CPR is if someone takes over care for you. So whether that's you transfer the care to the ALS provider on the ambulance, or you transfer care to the hospital. So those are the only reasons that we stop CPR. Some special considerations for AED use. Some general principles are that you check your batteries at the beginning of your shift and make sure that you have a spare battery in case if the one doesn't work for you. So you need to make sure it's actually operational. If you've delivered 3 shocks and ALS has not shown up, you should get the patient ready for transport. So 3 shocks is how the max amount that you want to do on the scene, unless if ALS is there or going to be there in a couple seconds. If you have an AED on the patient and they're in a moving vehicle, it's not usually going to be reading effectively because you have a lot of bumps in the road. And if you remember, AEDs are very sensitive. That's why no one can touch the patient. So keep that in mind, that the best place to be doing your shocks and analyzing is on the scene, not in a moving vehicle. If you do shock the patient, you need to bring the AED that shocked the patient to the hospital. It needs to be analyzed because it saves what rhythm it saw, and that way the cardiologist can look to see what was going on with the heart at the time of the shock. Remember to get ALS coming to you as soon as possible. So this is, even if the patient goes into cardiac arrest in your care and it was a BLS patient beforehand, notify ALS as soon as you can, because the quicker we get ALS there, the quicker the better chance the patient has for survival. And your actions might depend on the location of the arrest and the estimated time of arrival of the ALS team. So that goes back to knowing the amount of shocks that you give on scene. If you know ALS is just a few minutes away, keep the patient on the scene because it's more effective to treat the patient there. If ALS is 20 minutes away, load the patient up and try to intercept ALS or go to the hospital depending on where you are. So find out how close ALS is and tailor your patient care to that need. So if you arrive on scene and there's a bystander using the AED already, if the AED is advising shock, let them continue the shock. That's what the patient needs at that time. Then make sure that you get a report from whoever was providing care beforehand. Know how many shocks were given. Know if it said no shock advised. Know how long the patient's been down, when things were started. And also, just like with your AED, remember to bring the AED that was used to the hospital with you. Do keep in mind that in AEDs, sometimes the patches are not compatible with different manufacturers. So if you show up and those patches are not compatible with your AED, you can either continue using the AED that was there or take the patches off, put yours on, and use your AED. If you have a patient that has gotten a pulse back, so we've achieved ROSC, then make sure that we manage the airway. Again, use good BVM technique, avoid hyperventilation. Hyperventilation causes a tirade of problems, one of which could be gastric distension. The other one could be overinflation of the lungs, could lead to a pneumothorax, or overinflation of the lungs can create too much pressure in the chest, which then can compress the heart. We do not want to compress the heart because that will make the heart less effective, especially one that just came back from cardiac arrest. Keep the defibrillator on the patient. You can turn the defibrillator off, but keep the patches on the patient during transport in case they go back into cardiac arrest. It's very common for a patient to go back into cardiac arrest after their initial arrest. You'll want to reassess them very frequently and make sure that you assess their blood pressure, because their blood pressure is going to show if they are perfusing well or not. If they have a pulse but their blood pressure is 60 systolic, they're not going to be perfusing very well. So make sure that they have an adequate blood pressure. Do not be surprised when a patient goes back into cardiac arrest. It's very common to have happen. If it happens while you're transporting the patient, you can try to stop the vehicle and resume CPR, because again, CPR in a moving vehicle is not very effective. Try to get the AED back on. Again, the patches should have stayed on the patient, and analyze the rhythm and shock as soon as possible. So if you see them go into cardiac arrest, you want to shock them immediately. So if you have a patient that was alive when you got there, but they arrest in the back of your ambulance, that's actually good for the patient, because you should be able to provide care immediately. There's no guarantees that you'll ever get a patient back, but the chances are much higher with the early CPR and early defibrillation. So the best chance the patient has is when they are physically with you. You should, again, stop the vehicle and treat the patient in the vehicle just like any other cardiac arrest patient and get ALS coming towards you. Again, heavy emphasis on stopping the vehicle because manual CPR is not very effective in a moving vehicle. Quality improvement is huge for CPR. That's where our guidelines come from, is studying cardiac arrest. We can always improve individually and as a whole medical field. So it will include your medical director reviewing your cardiac arrests. It includes your initial training, what you're getting right now, maintaining your skills, so recertifying your CPR, reviewing all your cases, looking to see if your agency is trending either good or bad, and then strengthening the links in the chain of survival that we talked about earlier. Quality improvement includes maintenance of your equipment. That's why we check our equipment at the beginning of every shift. We want to make sure that things are operating properly and that we have a charged battery and we have a backup battery too. Mechanical CPR devices are becoming more and more popular, and they are great. They provide very high quality compressions, and it frees up the EMT to do other things such as airway management. So it automatically will provide the compressions, and they're usually very high compressions. There's a lot of studies out there, and some people will say that the studies are inconclusive as to whether mechanical is better than manual CPR. I personally, having used a lot of mechanical devices in my day, I personally have the opinion, so not fact, but just opinion, that mechanical CPR devices provide much better compressions, which then in turn give more favorable patient outcomes. That's just my opinion from my personal experience. I do not have any research to back that up. So there are two major devices that are used. One is called the AutoPulse, one is called a Lucas device. It's critical that you know the equipment that is used in your district and that you know how to use it. When I was a very new paramedic, I was working in the city of Syracuse, which the city of Syracuse uses an AutoPulse. Back then, it might still be today, but back then it was the busiest AutoPulse in the entire country. And we were at a house fire, and the Syracuse Fire Department carried the AutoPulse on one of their piece of equipment. It's called the squad, and the people in the squad were busy fighting the house fire, and a patient was pulled out of the house fire in cardiac arrest, and they just tossed the AutoPulse to me, my crew, and my supervisor, and went back to go fight the fire. No one from the ambulance company that I worked for knew how to use the AutoPulse because the fire department always did it for us, but the fire department was busy at that time. So we were stumbling around trying to figure out how to use the AutoPulse, and we weren't able to use it because no one knew how to use it. So know your equipment and know how to use it. If you are in an ambulance company and a fire district or a fire department in your district uses an AutoPulse, ask them to train you on it, or a Lucas device. Ask them to train you on it. If you carry that equipment in your agency, absolutely have someone train you on it because you're going to be expected to be able to use it as part of the equipment that you carry. If you have a failure of the system, please immediately revert back to manual compressions. Yeah, these systems do fail, and we don't want to be fumbling around for a few minutes without compressions because we're trying to figure out these devices. Do manual compressions if this fails. So going on into withholding resuscitation. So this is times where we are not starting resuscitation ourselves. The times that we are able to withhold resuscitation, these are the only times. 1, you have a valid do not resuscitate order. And again, this is even if you've started resuscitation, if you get this presented to you, you can stop. Second is an injury not compatible with life. This is like your decapitations, or if you have someone who was shot in the head and they are missing most of their brain, or you have someone who is burned beyond recognition. So injury that is not compatible with life. Next one is rigor mortis, or decomposition. So rigor mortis it usually happens about 4 to 6 hours after someone dies. Oh, correction, it can start within or about 2 hours afterwards in the person's face, but you're going to see this about 4 to 6 hours in the limbs. And this is the stiffening of everything. So if you try to move a joint that should typically move, it'll be very stiff. So that happens about, again, in the face, 2 hours, but 4 to 6 hours for the limbs where we're looking for rigor mortis. And that remains for about 12 to 24 hours after death. So rigor mortis is between 2 to 24 hours. You're going to be seeing some signs of it. Decomposition is the actual decomposing of the body. Oftentimes you can smell this. It's a very pungent smell. So if either one of those are present, then we withhold resuscitation. The next one is dependent lividity. Some people call this a liver mortis. But dependent lividity is when the blood vessels release the blood that's in them and it starts to leak out, and it will go to the area that gravity pulls it, so it's dependent on gravity. Typically, if a patient's laying down, you're going to be seeing this in the area that was actually touching wherever they're laying on. And there'll be a picture in the next slide of what this looks like, but it's a very obvious sign, and it says that someone's been dead for so long that the blood vessels have dilated because there's nothing to tell them to keep their shape anymore, and the blood has leaked out of them. Then the last reason that you can withhold resuscitation is a patient who's been submerged in water of any temperature for over 1 hour. So here's a picture of dependent lividity. So you can see that this purple area, that is what we call the lividity. So these areas were probably compressed by whatever they were laying on, and then these were the void spaces, so gravity pulled all the blood to these areas. So when you withhold resuscitation, it is then your job to pronounce the patient dead. You are legally the one who says that this patient is dead. When you make that determination, you should note the exact time that that was made. So sometimes you can ask your dispatch center for a timestamp and they will give you an official time. But make sure that you have an official, accurate time when that decision was made. You then have to notify law enforcement. When someone is dead, it is a crime scene until proven otherwise. So we don't know if there's any foul play involved to cause someone's death or if it was natural. That's not something that we can decide. So we have to treat this like a crime scene, and police will do it too. They'll treat it like a crime scene until it is proven not to be. So follow your general crime scene rules. You only disturb what you need to do your job appropriately. So if the patient is, for example, laying in a bed and they have covers over them, you can pull the covers back to assess the patient for rigor mortis or dependent lividity. But don't be changing things around in the room. Don't be moving things to the side that you don't need to touch to adequately provide patient care. When you pronounce a patient dead, you might need to give a deposition to police. If you happen to pronounce a patient dead and the responding law enforcement are New York State troopers, they will require a deposition from you. It's usually very quick, just you telling them what you found and why you made the decision you made, and that just goes into the record of their call. But that is something that might have to happen. You then have to thoroughly document all your findings in your chart. Document what you saw, what you touched, and why you decided the patient did not need resuscitation. The chart in New York State will be subpoenaed. Oftentimes the subpoena comes in before the chart's even completed, and that comes from the medical examiner who has to do their own investigation as to how the patient died. So this chart will be read by other people. It will be subpoenaed. So after you pronounce a patient dead, you have to be very concerned about the family members. A family member can become a patient themselves after receiving bad news, especially if they receive bad news in a not professional way. So a family member might become hysterical, they might become very anxious, they might even pass out for a second or two after receiving the news. So be aware that you might have to treat a family member that receives this news. You might be the one who has to tell family about the patient being dead. Because if they are expecting you to rush in and do all your resuscitative efforts because they don't know what makes a patient dead beyond our help or not, and you aren't doing that, you have to explain to them why. You have to tell them your family member died. Try to use the patient's name and always say dead. Don't say, oh, they passed away or they're in a better place. Say, this person died. This person is dead. Always try to speak in plain English. If you can, try to get them to sit down before they receive the news. That's not a hard and fast, you must do this, but try to recommend that they sit down before you talk to them. That way, if they have a sudden loss of consciousness from receiving the news, they don't fall. So revert back to the things we learned about in the well-being of the EMT chapter, where we talked about our own grief process, and just try to be very aware and sympathetic of the family. This is a rough time for them, and your ability to deliver the news and to be with them for the first few minutes is critical in how they will process this for the rest of their life. So be very sympathetic, be very empathetic, and be very factual. Never lie to them, and always speak in plain English. Don't talk over them. Try to use complex medical terms, but be definitive. Say that that person died. Let's go on to some chapter review. So, patients with cardiac compromise or acute coronary syndrome can have many different presentations. Some complain of pressure or pain in the chest with difficulty breathing. Others may have just mild discomfort that they ignore or that goes away and returns. Between 10 and 20% of heart attack patients have no chest discomfort. Because of these possibilities and the severe complications of heart problems, it's important to have a high suspicion and treat patients with these symptoms for acute coronary syndrome. The treatment will not hurt them and may help them. Patients with suspected acute coronary syndrome who are hypoxic or short of breath and need oxygen and prompt safe transportation to definitive care. You may be able to assist patients who have their own nitroglycerin in taking it, thereby relieving the pain and anxiety. To provide maximum chance of survival for patients in cardiac arrest, EMS agencies must strengthen their performance of the chain of survival. Those chains are immediate recognition and activation, early CPR, rapid defibrillation, effective ALS, and integrated post-cardiac arrest care. Remember, the heart is a simple pump that moves deoxygenated blood to the lungs and oxygenated blood to the body. Pressure within the cardiovascular system is critical to the moving of blood. Remember that acute coronary syndrome is a blanket term that refers to a number of situations in which perfusion of the heart is inadequate. Although there are common symptoms of acute coronary syndrome, EMTs must recognize atypical findings and err on the side of caution. Oxygen, nitroglycerin, and aspirin are key medications indicated to treat acute coronary syndrome. However, the definitive treatment is transportation of the patient to a facility that can open the blocked artery. Remember, most cardiac conditions are caused by arterial problems. Angina pectoris and acute myocardial infarction are caused by inadequate perfusion of the heart. Heart failure can be caused by either electrical or mechanical problems. Remember, the most important element of cardiac arrest care is the administration of high-quality chest compressions. The AHA's chain of survival describes the key elements necessary to maximize the cardiac arrest patient's chance of survival. Remember, AEDs provide early defibrillation in cardiac arrest patients with ventricular tachycardia and ventricular fibrillation. Post-cardiac arrest care is an essential element of cardiac arrest care. Mechanical CPR devices provide automated chest compressions in cardiac arrest settings. So let's think, what position is best for a patient with difficulty breathing and a blood pressure of 100/70? So, difficulty breathing, we want to have the patient sitting up. Usually a blood pressure of 100/70, we want them to be laying down a little bit, but that's still a perfusing blood pressure, and we need to have them sitting up because of the difficulty breathing. How about chest pain and a blood pressure of 180/90? That's usually a position of comfort, typically a semi-Fowler's position. And at this point, you should be able to know how to clear a patient before administering a shock. List 3 safety measures to keep in mind when using an AED. One is making sure that you know where the patient is laying down. Second is making sure that you have the pads attached properly. And a third would be making sure that you clear the patient before you shock them. At this point, you should be able to list all the steps in applying an AED. So you have a 78-year-old male who's been complaining of shortness of breath for 20 minutes prior to your arrival. When you arrive, you find that the patient is unconscious and not moving. What are your immediate priorities? So immediate priorities is you need to immediately perform your primary assessment. You need to find out, does he have a pulse? If he does not have a pulse, go straight into CPR with an AED. If he does have a pulse, look to see if he's breathing. If he's not, we need to be doing ventilations. So stay on your primary assessment and treat anything as needed in your primary assessment. So that brings us to the end of this chapter. A lot of material that we covered. And like I said, a lot of the stuff that we've been doing in class for a while now that we've just been kind of touching on, like the airway anatomy and the cardiac anatomy. This is stuff that you have to have memorized by now. This is why we've been doing this for a month. This is stuff that you have to know in order to understand why all these things are happening in the body and how we treat them. So please make sure that you have all the stuff down that I said you need to have down, and feel free to review any specific cardiac emergency that we went over, because this is all stuff that we commonly see in the performance of our jobs. So like I said at the start, respiratory and cardiac are the meat and potatoes of the medical emergencies that we see as EMTs. So until next time.